Our guest of today is Dr. Rokas Navickas from Lithuania. Dr. Navickas is a consultant cardiologist at the Vilnius University Hospital Santa Rescue, if I pronounce that correctly, and he is the co-leader of this work package on multimorbidity. For those of you who did not attend the first webinar, just as a very, very short reminder, the Joint Action CHRODIS gathered knowledge and evidence and good practice on how to prevent and manage chronic conditions, focusing on three main topics. One was on health promotion and disease prevention, which we tackled last week. Then on the management of patients with more than one chronic disease, which is now the topic of today. And then next week we will have the example of how to prevent diabetes as a case study. So I think this is it for now. And Dr. Navickas, it's over to you. He's going to tell us what the Joint Action has achieved in terms of care for multimorbid patients. Over to you, Rokas.
Okay, so once again, welcome everybody. My name is Rokas Navickas. I'm a co-leader of multimorbidity work package in the Joint Action CHRODIS. Thank you very much, Anne, for presenting me. Besides that, I'm a consultant cardiologist. I practice in Lithuania at the Vilnius University Hospital. And today I'm going to try to present briefly our 2-year results, which we have achieved together with our partners in the Joint Action CHRODIS, together with the leader Graziano and Dern, the co-leading partners, and obviously all the partners which were there. The Joint Action CHRODIS is still an ongoing project, Joint Action, and is due to finish March next year. And let me run through of what we have achieved so far. So what's the challenge? Multimorbidity. Multimorbidity is a condition when someone has 2 or more chronic conditions in the same person. It seems that the medicine in general has achieved so much over the last 100 years with antibiotics, with vaccinations, that most of the acute conditions, which would be lethal and deadly 100 years ago, now being treated, and some patients, instead of passing away, they are fully treated, but some of them carry on having a chronic condition. Chronic condition is prevalent. In the United States, 21% of total population have multimorbidity, meaning at least 2 of chronic conditions. And if we're talking about the people above 65-year-old, we are talking in the high 60% of the population. Let me run through a little bit of research. This is research which was a review of research projects, which was done between 1961 and 2013. And it just shares with you the prevalence of multimorbidity in people who are of a different age between 20 years and 100 years. As we can see, on the left side, we have people when they reach about 65-year-old, most of them in the populations already have multimorbidity. So on average, it works out that 65% of people who are at the age of 60, depending on the population, have multimorbidity. And if we talk about 85-year-olds, it's about 85% of that population. What's so special about people who have multimorbidity? Those people with multimorbidity, they are due to have premature death, so mortality is at a younger age. We see that they are much more likely to have more frequent hospital admissions, And we also see that their hospital stays are much longer. Again, looking at the data from the United States, we see that the person with a single chronic condition has a contact with the doctor or with a medical team up to 4 times a year on average, and someone who has 5 chronic conditions, he can have up to 14 contacts with a medical team. So, in other words, we are talking about a group of people, a considerable group of people who are very heavy resource users, and despite the heavy resource usage, they're still at a high risk of premature death, shorter life expenditure, and obviously worse outcomes in general. So we have touch-based the negative outcomes, which I just pointed you out. They are also people, they are the ones who are more likely to have disability. They are the ones who have high healthcare costs associated to them. And obviously they have low quality of life due to underlying chronic conditions. Taking all that into consideration, and putting that into perspective that they are the people who use the majority of our healthcare resources, that doesn't come together, meaning that something is not right. If we are using all the resources we have and we're still getting the worst outcomes, there is something wrong with how we do it. So when looking at the evidence for multimorbidity, there is really little evidence on that, and especially when we talk about cost effectiveness of an intervention for the multimorbid patients. Therefore, a joint action, CHRODIS, started about 2.5 years ago, and one of the work packages was based on multimorbidity. It was divided into 4 big tasks. First of them being aiming to identify targets of potential interventions for management of multimorbid patients. The second one was to review the existing care approaches for multimorbid patients, meaning that there are great ways, great examples in Europe, real-life examples in Europe, who treat multimorbid patients in the right way. They are getting very good outcomes. However, they are local and they are not spread. Therefore, the aim of this task 2, was to review the existing care approaches, try to identify what are the most important components which define the good clinical care of those multimorbid patients. The third task was to assess and select good practices on management of multimorbid patients. So based on the first 2, we aimed to combine one care model for multimorbid patients, which could be shared among different member states and used locally. And the fourth one, based on the multimorbidity model, which is how the patients should be treated, adjust that to the training programs so that the people who are trained at medical schools, they get the model during their studies. They get the insight, the knowledge at the very, very beginning of the career. So, going deeper in what we've done, task 1 and task 2 was due to be done during the first year of the joint action, and we wanted to identify the databases our partners from different member states had access to. We wanted to define the strategies for data analysis. We wanted to define the research questions which could be investigated on across different member states from different databases our partners had access to. We wanted to do analysis, to have analysis performed, and out of all of it, we finalized and published 7 papers and 1 editorial, which was published as a monographic issue of EJIM. Here you see the titles and the first authors of the published publications, which we did, and you can obviously find those on the internet, easy accessible. The things I wanted to make to note here is we had publications based on the Netherlands data, based on Lithuania's data, based on the Basque Country data, Spain, Finnish, and then a global healthcare overview of type 2 diabetes. So this is the added value we have from the joint action such as this, and having so many different partners taking active roles from different member states. So once we have done the database analysis and we produced the papers summarizing the analysis, we also took the next step of literature review. So we had the search strategy defined, and review performed, and paper which were produced in the literature on the same topic. What we identified, that patients with multimorbidity are at high risk, and there are targets which need to be aimed for interventions. And those were disease patterns, such as individual diseases or combination of diseases. It was low socioeconomical status, which was again affecting the worst outcomes, such as low income, poor social support, poor physical function, and obviously mental health problems, such as depression and cognitive impairment. So we all agreed that those are the ones which need of comprehensive assessment and intervention. The second task, which we had, was based on the literature review to review the existing care programs for patients with multiple chronic conditions, and we finalized that with systematic literature review. Summarizing it, we had 20 publications of studies which were selected for evaluating. 19 comprehensive care programs for multimorbid patients were identified. Programs varied in the target patient groups, implementation settings, number of included interventions, and number of chronic care model components to which those interventions related. Strong evidence was found for a beneficial effect on physical and mental health status. However, insufficient evidence or no evidence was found for improvement on other outcomes. Different components of the interventions were identified: health system, community resources, self-management support, delivery system design, decision support, and clinical information system. And out of all of this information, we tried to pinpoint the components which were there to provide the best possible outcomes, and try to identify through that the best possible multimorbidity care model. One more thing which we wanted to summarize from the literature review which was done by our partners at the NIVEL. Many recent initiatives on care programs in Europe targeting patients with multimorbidity or frailty frailty are available. Different key components can be identified, but programs are extremely heterogeneous. Programs aim to increase cooperation, improve coordination of care, and reduce use of care services. Positive outcomes are often reported or perceived, but not much strong evidence based on scientific literature is available. And strong evidence that comprehensive care programs can improve patients' physical and mental health status is available. So, concluding the task 1 and task 2, we analyzed the databases our partners had access to understand what the situation is like in different member states. We also then reviewed the literature, the care pathways, to identify the absolute most important components in the care of the patients. And then we said we needed to define the best possible care model. This is what we came up with after the whole work during the first year. Now, I'm not expecting you to read through all of it. I'll go one by one. Basically, we have 5 big groups, such as delivery of system design, we have decision support, we have clinical information system, we have self-management support, and we have community resources. We ran into some discussions about, we have so many different member states, we have so many different healthcare systems. How can we have a very unified one care model, which is one fit for all? And we decided that we will probably provide a care model which covers the core of the problem, which covers the basics of what needs to be taken into consideration, and leave the other as optional for the member states to decide on if they want to add on to their care model or not. To help us to do that, we had an expert group, and we aimed for an expert consensus who are people working in the field. So we had the Joint Action CHRODIS experts, we had good clinical care components, which I just showed you, and we're going to once again go through them. And out of those 2, we came up with a guidance on multimorbidity care model. I'm now going to have 5 slides going through the multimorbidity care model in a very, very superficial way, because it will take too much of our time. However, all of you can find the information in the Joint Action CHRODIS webpage at a much more detailed format. So, looking at the first big group, delivery of the care model system, we had 4 components which we highlight. It's a regular comprehensive assessment of the patients. We have a multidisciplinary coordinated team responsible for the patient's care. We have professional appointed as coordinator of the individualized care plan and contact person as a single contact for patients and family, acting as a case manager. And we have individualized care plans done for each and every patient. Why I have the second one highlighted or bolded is because we feel that the fact of having multidisciplinary team, which is coordinated and has a single contact person who acts as a coordinator of care, is probably one of the most important first steps we need to make to ensure a homogeneous care of those patients which we're talking about. The second group is decision support, and this has again 3 bullet points. One of them is implementation of evidence-based practice, which is a difficult one because we are still lacking a lot of evidence on multimorbidity best practices. We have training members of the multidisciplinary team to make sure that they are aware of other disciplines. They are aware of how to best coordinate the care of those patients, make it smooth, make it applicable, and making that the patients are actually getting what they are aiming for, what they need, at the quickest and best and most efficient way. And developing a consultation system to consult professional experts, meaning that if we have one team responsible for the care of those patients, that responsible team has to have a accessibility to discuss the cases with professional consultant experts when it becomes tricky and difficult. We have self-management support, such as training of care providers to tailor sales management support based on patients' preferences and competences. We have providing options for patients and families to improve their self-management and shared decision-making, obviously involving the patients as much as we can, as well as the care provider, who is the next who is the first person to be next to the patient when he or she is in need. The other group is information systems and technology. Now, 4 things we need to touch base on. One of them is electronic patient records and computerized clinical charts. That is available in some parts of the world, but not all of them. We need to make sure that we exchange the information about the patient, obviously with the permission of the patient, between the care providers and sectors by compatible clinical information systems. What does that mean? That refers to what I've just spoken about a few minutes ago, that each patient has to have an individualized care plan. Each patient has to have information about that, about the discussions and all the teamwork which was put in to make sure that the patient is on the right track. Now, this information to be digested and made available, it allows a lot of time of the team for it to happen. Now, if we don't share that information, when a complicated multimorbid patient comes to a hospital, as an example, and nothing or very minor information is accessible to the hospital team, they invest a lot of time and a lot of additional effort and money to actually get to the same level where the coordinating team was already. So this exchange of patient information needs to happen from down up as well as from up and to down, meaning that when the patient is discharged from the hospital, the information seamlessly needs to travel to the coordination team so that they can adjust the care accordingly. We have to have a uniform coding of patients' health problems where possible so that we can actually talk the same language between the different teams and care providers. And we have to have patient-operated technology allowing patients to send information to their care providers, allowing them to stay away from the hospitals for longer, allowing the care providers to monitor their state of health without actually going there and being there, especially when the patient is more or less right. And we have social and community resources, meaning supporting access to community and social resources and involvement of social network, including friends, patients, patient associations, family, and neighbors. Now, I would like to touch base on the second one. We're living in a environment which is, in a way, very connected. We have social media, which might come into hand. So here we are talking about social network, informal social network, which includes not only the family, it includes the neighbors who can check on you now and again. It includes the friends who can again help for you to support you when you're in need. So this is a very brief overview of the multimorbidity care model, of the components which were selected as the important ones and have to be included in every multimorbidity care model across different member states. Now, once we created and agreed that this is the care model which needs to be spread across different member states, before we do that, we wanted to make sure that this care model is applicable across different healthcare providers and healthcare systems. So we decided to assess the applicability by contacting different stakeholders, asking them to evaluate if all the components are applicable, obviously, to a varying extent in their healthcare setting. We had 16 components, we have 29 countries, we had country experts with a balanced composition. We including governing board members so that we get a deeper insight from the governing board perspective. And we did it via online questionnaire, which we send to all the participants and then analyze the data. This is the coverage which is showed of which member states were involved and replied to our applicability assessment. So it covers almost all of Europe. And this is a short overview of what we received. We had 21 responses from countries like Belgium, Bulgaria, Cyprus, Croatia, Estonia, Finland, Germany, Greece, Iceland, Italy, Luxembourg, Netherlands, Norway, and Portugal. We had 4 responses from the governing board, which was from Cyprus, Croatia, Belgium, and Estonia. And in a very, very short sentence, all countries apart from Cyprus, Bulgaria, and Greece did not report non-applicable components, meaning that all the 16 components were more or less applicable. Depending on the country, the variation was applicability between 1 and 10, but they were applicable. There were some occasions where the countries did not comment on the component, but as I said, none of those except of those 3 reported non-applicable components. The average scoring of components applicability was from 7 as a maximum to 5 as a minimum. And you can find a detailed country status in the report, which is again accessible through CHRODIS Joint Action webpage. I have to say we also left some space for comments for the responders, and those range from worth ranking the components, change the legislation to implement the model is needed in the country, efficiency should be included in the components. Some of the responders already started piloting the care model. Some of them questioned the interaction with NICE guidelines, and some of them just said that very powerful product of the joint action. So this was the end of task 3, and then the task 4 is about defining multimorbidity case management training programs, so that people who come out of their medical schools or their training have actually an idea of what the care model looks like, of what the components look like, what they need to take into account when looking after the patients, and so that happens at the very, very beginning of their careers. How does the activity look like? The activity looks like of production of questionnaire to assess existing case management training programs, which already happened. Email questionnaires and collect data from questionnaires, review of the scientific literature, which is happening now, produce a summary document, which will happen in the due course, identify experts on training programs, and then organize an expert meeting to produce recommendations on the training programs. So, in a nutshell, we have a big problem of multimorbidity. We have a big group of population who is using vast majority of resources. To be honest, 74% of all healthcare resources in some countries go to multimorbid patients, and this is only 22% of the population. So those are the high spenders. However, they're still having the worst outcomes. We have created a multimorbidity care model based on the literature and on the data what's available. We have had reviewed it by the member states, which confirmed that most or all of it is applicable across. We have shared it with all the member states across Europe, and now we are ready to start adopting it, which will be the aim of the next joint action to come. Thank you very much for your attention. I'll leave some time for questions.
Thank you very much, Rokas, for this great overview of the work done on multimorbidity. There are a few questions, in fact, so I don't know if Maddalena Ilario, if she can. We will unmute all participants, and Maddalena, I don't know if you can hear, and if you would like to state your name and your organization, and start with your first question, perhaps.
Can you hear me? Hello?
Yes. Yes, I'm with you, Maddalena.
Go
ahead.
Hello?
Yes, we can hear you.
Hi, good afternoon. Hi, Rokas. Very nice presentation. Thank you for sharing the results of the project. I work in the IP, and I am a coordinator of our Campania reference site, and I'm very interested in your results because in our experience, management of multimorbidity poses a number of challenges. So my first question concerns the coordination of the care team. Is the case manager also coordinating the multidisciplinary care team in your model?
Thank you very much for the question. The case manager is responsible for making sure that all the care is smooth, delivered on time, and that the patient is as the team expects him or her to be. So in other words, it's like a manager in a way. Now, obviously, the case manager, the case manager is not necessarily someone who's got so much medical background. It would be a waste of very precious resource to put as an example, a team, the head of the team, such as a GP or internalist, to manage everything. So the GP or internalist is managing the medical side, whereas the case manager is managing the operational side of everything happening, what needs to happen, the team to be updated on what happens if there was an admission to the hospital, etc., etc. Did I answer your question?
Yeah, it's perfect. So another question is, who signs the prescription to the patient of all multidisciplinary team?
Well, again, this is a very good question. Now, this depends on the member state. On some occasions, the nurse, which could well be the case manager, is allowed to sign the prescriptions. In other cases, it's just the doctors who are allowed to prescribe it. So here, this is a question basically to the member state, if they are allowed legally for the care, the non-doctor to be prescribing the medications. If there is no change, this could possibly be done by them, but it depends on the member state and on the local healthcare regulations.
Yeah, and another thing is about the revision of polytherapy, because we realize that there is a big issue for multimorbidity patients about prescription of polypharmacy. So did you envision in the future or in this current multidisciplinary team a moment where you revise polytherapy? You know,
Yes, that's a very good point. Polytherapy is a big issue, which is affecting many side effects, bad outcomes, etc., etc. Now, we identified this as one of the priorities. However, in this joint action, we didn't have enough time and resources to pursue that as well. However, it's still on the plans, and we're considering revising all the options so that we can propose to the member states what are the tools which could be used to reduce the chance of polypharmacy and related worse outcomes and side effects.
I don't know if you heard about Sympathy project that is coordinated by Alpha Namer of Scotland. So it could be possible that you know, we exchange a few ideas about this. It could be a good synergy between CHRODIS and Sympathy.
Exactly. Exactly. Thank you very much for that, and I completely agree with you.
Yeah.
And those sort of synergies we're going to be looking at while trying to identify the means, because now we only have broad components which every member state has to take, adapt to their local culture, rules, how people are used to working, and implement it their way, but making sure that all 16 are there. So what you questioned about the polypharmacy is exactly something what we can actually feed to them and say, look, those are the possible ways of you addressing polypharmacy in your healthcare setting based on this project, that project, or some other research. So yes, thank you very much, Madam Anna, for your proposal. Last
thing. One issue, at least in my region, is the ICT literacy of older adults. So you mentioned to involve them in self-management of their case. And did you have the opportunity to assess the ICT literacy of your population while you were studying them? Target population, I mean, the morbidity of the others.
Let me repeat your question because I'm not sure if I got all of it. The question was if there is a problem with patient literacy and self-management, therefore maybe not as smooth as we expect it to be, and have we done any work to identify patient literacy and how that affects their self-management?
ICT literacy in the management of the tools, because you mentioned that they should manage some tools. So how do they manage? Did you embed in your model an ICT literacy intervention?
Well, they will have to be very clearly. We haven't gone into very more specific details because that will have to happen at a very local level at very different member states. Now, and obviously different communities, because that also varies. If we're talking about a nursing home, that's one. If we're talking about a big city, that's something else. Now, we will have to provide patients, obviously, the tools which are accessible for them, the ones which they can easily understand, either themselves or care providers. So this will be a very, very local work job while adjusting and picking the right tools for the right patients. I completely agree with you that the ICT literacy in general, understanding of your health, education of the patients varies hugely. And we're going to have issues there, struggles there, but on the other hand, this is a huge potential which is underused today, so we need to look for ways to how to make it work.
Yeah, great. Thank you so much. Thank you.
Thank you.
Thank you. Are there some other questions?
Hello, I'm Elena Berti from Italy. Can I ask you something?
Sure, Elena, please go ahead.
Okay. I would like to know something more about the literature review you have performed. And I would like to ask you to tell me something more about the outcomes deriving from the application of multimorbidity care models. What can we expect, and if you know, if you can suggest some indicators to monitor the effectiveness of these models. I know that there is little evidence about it, but I would like to know something more from you. Thank you very much.
Thank you very much for your question. Before I start answering, I'll request Anna and Anne, when they are sending an email to you all, to possibly include links to the literature review paper and also the 7+1 papers which we produced from the data analysis, so that you can actually have a really good look at what was found and shared. Now, answering to your question about the KPIs of good clinical care in this group, I should start from saying that every good KPI should be somehow related to cost effectiveness. Now, there is virtually no data on cost effectiveness on multimorbid patients. We looked at the literature. It has the components, but it has virtually nothing saying about which ones of them are cost effective, which of them are effective at all. So this is a major field, a major research possibility for the nearest future to identify the cost effectiveness of either those components or any other components, to identify the most efficient KPIs to be used and shared. Now, you might ask a question, why is that the case? Why is it not available? And the answer is, from looking at the literature, we see that, as I stated in my presentation, the care is very heterogeneous. The groups are very heterogeneous. We had a big struggle agreeing between our partners of what is multimorbidity, what actual diseases does it involve, which, I mean, this is the first question you have to have before you start a research on cost effectiveness and KPIs. And we realize that different groups work with different lists of diseases. Some of them have 40 diseases, some of them have 32 diseases, some of them have 56 diseases. So they are extremely difficult to unify and come up with one conclusion on the KPIs. So I'm afraid I'll have to direct you to our paper to get more information from there. But concluding very short today, I don't want you to be disappointed. There will be not an answer to your question, because as far as we have looked through the literature, there is none available so far. Again, I know that some groups, some research groups are putting calls together for Horizon 2020 and others to work on the cost effectiveness. But this is still probably due to come.
Okay, thank you.
Thank you, Elena.
Are there more questions? You can just go ahead and without having to ask.
A question to the organizers, if it's possible to receive by email also the presentation, the PPT file, so that we could...
I forgot to mention that at the start of the webinar. In fact, the presentation will be available on the website, but we can also send it to you. That's not a problem.
No, it's okay on the website, of course. Thank you very much.
Rokas, could you maybe tell us a bit more about the implementation of the model in the Netherlands? How far they are on the?
Well, they are working on implementation for almost a year now, full hands-on. We still are too early to get the results, but those results will be a good start of the new joint action, which will be basically based on implementation. So we're going to have 3 pilot sites across different member states. We're going to have, by the end of the new joint action, we're going to have this care model, which now looks rather broad and unadjusted. We will have it adjusted for a number of different healthcare settings in different member states. So NIVEL, who's responsible for implementation now, that's what your question refers to, will basically build the background for the implementation which we're going to be working at. So it's a little bit too early to talk about the outcomes. But as far as I know from NIVEL, obviously implementation is not that easy, and the care model needs to be adapted first to the local setting before you actually take and implement it into practice. So it's a little bit early, Anne, to talk, but I can reassure you that we're going to be coming back to you with the results either by the end of this joint action or early when we start the next joint action.
Okay, thank you. Are there any further questions?
The next joint action will be still CHRODIS or the new project.
It will be a completely new joint action based on chronic diseases. However, to maintain the momentum, to maintain the knowledge of CHRODIS, the next project might have a name which is very similar to CHRODIS, so that there is a linkage between those two.
Very similar, so to CHRODIS. Okay.
So the name will be very similar. The project itself is completely new. Some partners are the same. Some partners will be new partners, but it will be people working on the same issues.
Okay. Thank you very much.
And obviously, taking the outcomes of this joint action and furthering that. Are there no more questions?
No from me.
I think we can. I think we can stop if there are no further questions.
Well, in which case, I thank everyone who attended. Thank you very much for your questions. It's always nice to get some. You can find a lot of information on the website, and Anna, I would be grateful if you could just share the links of the literature review and then the AGIM publications as well.
Sure, we will do so. So we would also like to thank all the people who attended the webinar today. And just one or two reminders. First, that we are going to send you an evaluation form, so please fill it in, because that helps us to improve our webinars for the future. And then the other reminder is that we have the next webinar next week, the same, again on Tuesday at the same time, and this time it will be on diabetes and the management of diabetes. We will send the link on Monday afternoon for Tuesday. So yes, thank you all, and have a good rest of the day, and see you next week probably. Thank you very much, Rokas, for your presentation.
Thank you very much. Thank you all.
Thank you all.
Bye.
Bye-bye. Bye.
Bye-bye.